Barry, if we can just bring you in now, if you don't mind, a very warm welcome to you. If you could just give us a very brief overview of your perspective of the guidelines, and in particular, if you can focus on how we can try to prevent those patients having those catastrophic AF-related strokes. What can we do more in this space?
Okay, thanks very much, Dr. Yavid. From my perspective, I think the first thing that we can do, and my name is Barry McDonnell, I'm a cardiovascular physiologist here at Cardiff Metropolitan University, but I think the first thing that we can do in our fight against AF-related stroke is to try and increase awareness and early detection, because I think this is the first point of contact by which the individual would be made aware of their condition and then be able to do something about it. The problem is at the moment that there's a lack of individual and population awareness about the condition, and early detection is first and foremost to try and to prevent these strokes. The more we can detect those of us that are, or the people in society that have AF, then the more we can do something about it. It goes without saying, and after a really nice overview from Professor Osman, AF categorically increases our risk of AF-related stroke. That goes without saying. But importantly here, and you can see on my slide, that approximately 20% of those who have AF-related stroke are only diagnosed with this AF at the time of when they present with stroke in the hospital or shortly thereafter. So it's really important, and like the case study you mentioned at the very beginning, we try to get early detection as soon as possible to maybe see if we can protect against that individual progressing to a catastrophic AF-related stroke. I've got some information from the AF Association and the screening survey, and I think it's really important to highlight here that the challenges that we have for diagnosis, and you know, when we look at the AF screening study, we can see clearly that there's nearly 30% in those over 71 years. There's 41% sitting above 61 years of age. But quite staggeringly, we have 30% of those that diagnosed with AF are under the age of 60, which again is quite an important issue for highlighting that there's people out there that maybe not at the high risk in terms of epidemiological data, but are presenting with this high levels of AF under the age of 60. Importantly here as well is that we can see that those that are presenting and in the AF screening have received screening following symptoms. So symptoms have preceded those going on to getting a AF detection by the healthcare professional. But really importantly here on the right, at the lower right area here, is that 7% of those with AF had no symptoms at all. And I think this is a really important subgroup of people, again, out in the community that are asymptomatic, that are walking around without understanding that they are at high risk of AF-related stroke. And it's those individuals that we need to be really trying to focus on, as well as those in the older age groups which have a higher risk. But we can't forget about those with that asymptomatic and the cohort. So this is really important, and I think it was alluded to by Prof. Osman that this study here clearly shows that if you are asymptomatic, that doesn't rule you out of having an increased risk of having stroke and death. This study here quite clearly shows that those that are asymptomatic after a follow-up of 6 years had a similar risk of stroke and death compared to those that are symptomatic. So having no symptoms whatsoever does not protect you from the risk associated with AF. So I think that's a really important point that I think awareness needs to be driven upon and worked upon, and will allow us to understand the population to understand that, you know, you need to take this seriously if you present with or detect with AF. And I think awareness is the key issue here. In patients with AF, and again, this comes from the AF Association survey that they've done, 37% of those with AF were unaware that AF actually causes clots. 40% were unaware that AF leads to a stroke. And again, 48% are unaware of the reasons for anticoagulation. So I think we have a real job to do in terms of awareness and providing knowledge to the population of patients and also the wider community about AF awareness, understanding the risks associated with it. And it was only through that we can really address the risk on a population level. we know that the AF Association and have written this white paper document to try and address these issues and try and bring forward some of the key focal points for how they're going to address AF-related stroke. First one being prevention and awareness, where understanding AF is at the forefront, and what you can do potentially to prevent or to reduce your risk of AF-related stroke. Then comes detection. So again, it factors in and it aligns with the Public Health England and the NHS 10-year plan of trying to increase early detection rates in the community and making every contact count. Because if we have people that are going to a healthcare professional for some other reasons, if they're having their blood pressure measured, for example, then why not have AF detection measurement done at the same time to hopefully catch some of those population that may be unaware that they have AF. That then leads to protection. Once you've been detected with AF, you can follow the clinical guidelines like Prof. Osman has clearly identified and alluded to. And that leads to then the overall perfection of correction and perfection of the AF for individuals. Now, through correction, we can improve modifiable risk factors, like Prof. Osman said, one of the key ones being improve to reducing levels of obesity, alcohol consumption, smoking. All of these risk factors can be helped and can be modifiable. And that will then lend itself to the perfection, i.e. the maintained engagement with the healthcare provider to manage the condition for the patient. And we have all this in the AF Association white paper document that is there, clearly identifying prevention, detection, protection, correction, and perfection of all those key facets. And I think that initially is the first step that we need to take to try and increase the awareness and increase early detection to try and get a better handle on this AF in the community. And that's back to you, Dr. Yabbott.
Thank you very much, Barry. Great messaging. Really important call to action. I mean, I think the AF Association have done so much actually in terms of driving awareness and greater sort of prioritization of AF detection and management, particularly in primary care. So I think now's would be a good time for another poll question, if that's all right. I'm not sure if that can be put up on the screen. It'd be really interesting just to gauge the sort of level of understanding in the audience in terms of what causes AF to lead to AF-related stroke. And you should have some options coming up at the bottom of your video player. And I can see the second option. I'll just leave that on for a few seconds, actually, while we're getting people to mull over those answers.
I think from this perspective, Dr. Yabbott, that it's very important to understand that AF doesn't have just one particular mechanism why it drives AF-related stroke. It has a multitude of factors that end up driving risk, and it's important to take this holistic view in terms of and understand the reasons why this is particularly happening and why these patients are at higher risk for awareness, but also for potential future management.
I totally agree, Barry. In fact, you could argue that all of these responses here available are all interlinked in the patient, and you've got to have this broad sort of holistic strategy to try and address the issue. But most of the audience are putting down increased thromboembolic risk. So I guess that's the traditional way of looking at how AF causes a stroke. You get this mechanical stasis of blood within the atria, particularly within the left atrial appendage. The stasis causing the clot to develop, and that clot is almost a ticking time bomb that can break off, go straight into the left ventricle aorta, and it usually goes straight up the carotids and blocks a major artery. But clearly there's a lot more complexity to it than just a sort of mechanical mechanism that we've just described. So, Barry, should we move on to the next part of your presentation? We've sort of mentioned that it's the early detection of AF that is probably the biggest challenge that we have to address if we want to make a meaningful impact. So give us some strategies as to how we can improve that early detection and awareness for our patients?
Just before I do, in relation, just to quickly address some of the poll and this holistic view that we were just talking about, I think the audience are quite right. The thromboembolic risk is obviously a major issue, and again, that's the origin of that is back at the atria and the stasis that creates the clot formation. But I think it's really important to also identify that this disruption in hemodynamics doesn't just sit in the chambers of the heart, and that, as you quite rightly said, gets transmitted right the way into the ascending aorta, into the carotid, and up right the way through and transmitted to the brain. And it's that insult or hemodynamic instability and turbulence in flow that we can see that gets all the way to the brain. And one of the slides I have here is you can do a transcranial Doppler that allows you to see that the bottom left of your screen will see that this is the flow profile going into the brain. So again, this is highlighting that the hemodynamic changes associated with the atrial fibrillation originating back at the heart is actually transmitted right the way through to the brain. And it is really important because it determines the type of blood flow that gets to the brain, but it also back downstream in the carotid. If there's already a clot that has formed and adhered to the edge of the arterial wall, this turbulent flow has got a greater chance of dislodging this clot, and then that gets transmitted to the brain. And this is where I think hypertension also has a role to play in being the driving force, the mechanical energy that then combined with it will really drive on and increase this risk of clot disruption from the arterial wall and being transmitted to the brain. But in terms of hypertension itself and AF, in terms of the risk of stroke, we know that there's a lot of similar risk factors that are associated with it. Obesity, we know smoking, sleep apnea, but also endothelial dysfunction. When you have a turbulent hemodynamics that leave the heart and go towards the brain, you also affect the endothelial function of the arteries that this blood clot or blood pressure and flow gets transmitted through. Now, if you combine those risk factors with hypertension, then that exacerbates the risk of having your stroke. But combine it with atrial fibrillation, you have a double and a deadly combination of thromboembolic risk originating from the heart, from the atrial fibrillation, combined with a high pressure that will then increase your risk of developing and transmitting this highly problematic clot to lodge in the brain and therefore create the risk of the stroke. So I think the combination of hypertension and atrial fibrillation is very important to consider, and I know it's been proposed in many studies where hypertension itself is a precursor for development of new onset AF. So it's important to try and keep that in mind. You mentioned then in your question what can be done on maybe a more community-based global level to try and address this risk and to try and increase awareness. Well, we, as part of the May Measurement Month Blood Pressure Awareness Campaign, have been trying to address the blood pressure inequalities, the understanding of undiagnosed high blood pressure in the community. This year now we're pairing up with AF Screen Global Campaign to try and combine, when we're doing some blood pressure measurements, to do an AF detection at the same time, highlighting previously that the interconnection between hypertension and AF is such a critical measure, and both together increase your risk of stroke. It's a perfect match to try and increase community-based detection. Previous years, what we've been doing, we've been trying, like you've suggested previously, we've been opportunistic screening of our early detection awareness campaigns that we've been doing have to try and reach out into the community to get more awareness, more detection of those walking around with high blood pressure. And as I said, this year now we're going to be moving into and combining this with AF Screen to try and prevent AF related strokes and improved detection of AF in these communities. We've done a lot of promotion of this campaign through the Lancet, European Heart Journal, and we've tried to use these campaigns and using celebrity endorsements to try and increase this awareness even further. As Professor Osman has quite eloquently alluded to, these various different devices that are now on the market that will allow us to improve early detection. And again, it's critical that we're using devices that are being well accepted, they're valid, and they give us accurate readings. And again, with the complete device here at the bottom of our screen, we are going to be using some blood pressure measurements and AF detection at the same time, because the complete device has the Alive Core, the system inbuilt into it, which allows us to be able to measure blood pressure and AF in every participant that comes through. So this is where May Measurement Month and the AF screen will come together, and using technology, we'll be able to get this out into the wider public. Of course, we'll be adhering to the guidelines, and this early detection identification process, together with the May Measurement Month protocol, will be informing participants about the significance of implications of AF. So again, a lot of awareness in this perspective. We'll also be informing them of a structured referral platform, which has been advised and devised with clinicians, that once detected with the systems, that is considered possible AF until the arrhythmia specialist or the GP has actually seen the rhythm, like Prof. Osman has previously suggested. So this is not a diagnosis, but a possible detection of AF for future consultation. And there's a lot of resources that we've provided from AF Association, Arrhythmia Alliance, Knowing Your Pulse, and videos to how to go about doing this and understanding what your pulse means when you can palpate it, in addition to all our blood pressure awareness details and guidelines that we have for May Measurement Month. And at the end here, I guess I've got some resources here that people can click on and use for both the May Measurement Month campaign and the Arrhythmia Alliance AF screening collaboration that we'll be undertaking.